So let's maybe take the same concept and apply it to a different clinical situation. So we move into, first line metastatic renal cell carcinoma, and we're, in a lucky situation, I would say, where we have sort of a smorgasbord of treatment options, starting with, dual IO therapy showing benefit over Sutent, I guess now probably like 7 years ago or something. And now, at least in our region, an IO-TKI combination is kind of the standard of care. How do you, consider all the treatment options in this disease space and make some treatment choices about what to actually initiate for any given patient?
Right, so this is a $1 million question, right? So we went from, as to your point, from target therapies, immunotherapy, sunitinib, pazopanib, and then cabozantinib, to actually a combination that involved immunotherapy. Initially, we started with ipi/nivo and two IO, two immunotherapy agents, and then we found out that combining immunotherapy along with the target therapy works really well as well, and we have a number of them. Lenvatinib, pembrolizumab is one, certainly, as well as cabozantinib, nivolumab, axitinib, pembrolizumab, are also approved. So you really have 4 combinations that have shown to improve overall survival. We should also add that in the old day, we developed these poor prognostic. Well, not we, because I wasn't involved in that, but very smart people. Yes, I should give Dr. Hang and the group and Tony and and many others, Brian, a lot of credit for doing that. But it was develop a prognostic score, a risk score, right? That basically gets patients into boxes. Favorable or good risk, intermediate and poor or high risk disease. And what that allows us to understand is that comes out of a multivariate analysis and help us to inform patients what the outcomes would be. Now, this was done many years ago when the new way of treating this disease was not available. The reason it's relevant is because we use that score and we try to embed that and incorporate that in all the phase 3 trials that led to the approval of these IO-based combos. And my point of saying that is because it's relatively imperfect, right? Because it was never validated to answer the question, are they really predictive? And the reason why it's important is because you look at the guidelines and you see the breakdown depending on the risk, how you're going to treat and how we approach patients. So for example, if you want to think of ipilimumab, nivolumab, in the guidelines, there's no recommendation in the good risk population. Why? Because the primary endpoint was focused on the intermediate and poor risk, for example. Whereas for the IO-TKI combos, any of the IO-TKIs that are approved currently, indeed, they include good risk. So that's one aspect. There's a number of aspects. Often in our academic way of thinking, I would argue that we are very attractive to things like sarcomatoid features. We're very attractive to think of, treatment-free interval, potentially long remissions. We have the hope that those 10% or so of patients who achieve a complete response will not need subsequent therapies over time. So it's very important to see what happens over time. So we've seen at ASCO GU is actually updates, longer follow-up for these IO-based approaches. On another hand, for patients who are very sick, very symptomatic, have visual crisis or a lot of high tumor burden, and you really think that that's it. It's the only chance I have to regain control of this cancer and help this patient right away. You tend to use the therapy regimen available to you that minimizes the risk of not working or maximize the risk of success. So you tend to use and you tend to use the regimens that offer you the highest response rate. I would argue between lenvatinib, pembrolizumab, cabozantinib, nivolumab, right, and perhaps axitinib, pembrolizumab. Going with an IO-TKI allows you to do that because you do see responses happening sooner, and you have overall about 20% or so higher response rates. It doesn't appear, at least the data was presented, it doesn't appear to what we know thus far, the median OS is that different among the different regimens, and we don't quite know, if there's one better than the others. There's certainly regimens that we believe they might be suitable for certain patients compared to others, right? And I do believe that, for example, patients in visual crisis, high tumor burden, symptomatic, I think a lot of us or most of us would choose an IO-TKI. I think for patients where we have the time and we can have the question, is it possible that offer long remissions, time without treatment, sarcomatoid features, I think a lot of us would tend to offer a dual immunotherapy combination like ipi/nivo. Right. And then beyond that, I think the conversation kind of gets lost a little bit because we've never compared these different regimens in a prospective randomized manner, and ultimately, potentially we would need that. I'm not sure that will be done, but I do think we need to figure out more, in my opinion, more important questions, because unfortunately, most patients will still progress on these very active regimens, and what to do upon progression, I think, is where the focus needs to be, and at the same time, also certain patients that might be treated in a different way, for example, the oligometastatic disease, understand a little bit more in the context of the novel regimens out there, how do we best approach them? Should we resect them, become the non-metastatic disease and offer adjuvant immunotherapy as monotherapy, or should we offer with a dual immunotherapy-based approach with addressing the sites of metastasis? So those type of questions I think are very relevant today. I think we're learning a lot, and I do believe that data like the one that was presented at ASCO GU is relevant to move the field forward and help more patients.
Absolutely, and I think we put it all together. I think we're sort of at the precipice of getting truly patient individualized care, and you're sort of highlighting a variety of different ways that we're sort of just getting to that edge of trying to get real personalization and identify really the right regime for the right patient at the right time. And I think it's really great to see all this data helping us get closer and closer to knowing what the exact ideal approach for any given patient is.
Right. No, I fully agree. And I haven't mentioned, by the way, most of what we said today is applicable mainly to clear cell subtypes, right? And it's not that we're forgetting and talking about the non-clear cell histologies, but just to say it's a far more complicated than someone coming to clinic and with a diagnosis of renal cell carcinoma. There's a lot to go into it. There's a lot we know more, and more that we take into consideration in our decision process. Maybe the conversation for non-clear cells, we save it for another day, but it's that complexity is relevant because we are understanding more, right? Absolutely. And we are not addressing all these patients the same way. And I think ultimately that is an important message.